You are listening to Specifically for Seniors, a podcast designed for a vibrant and diverse senior community. I'm your host, Dr. Larry Barsh. Join me and a lineup of experts as we discuss a wide variety of topics that will empower, inform, entertain, and inspire as we celebrate the richness and wisdom of this incredible stage of life. Welcome to Specifically for Seniors. I'm your host, Dr. Larry Barsh. Today's guest is a practicing physician, Harvard professor, and one of the most thoughtful voices on how AI is reshaping medicine, not in the distant future, but right now in the exam room. Dr. Adam Rodman is a general internist at Beth Israel Deaconess Medical Center, an assistant professor at Harvard Medical School, and the director of AI programs for the Carl J. Shapiro Center for Education and Research. He leads Harvard Medical School's task force on integrating AI into the medical curriculum, serves as an associate editor at the New England Journal of Medicine AI, and is the host of Bedside Rounds, the American College of Physicians podcast on the history and evolution of medicine. His book is Shortcuts, Medicine, Navigate Your Way Through Big Ideas. Earlier this month, Dr. Rodman wrote a widely read guest essay in the New York Times entitled Take It From a Doctor. It's okay if your medical advice comes from AI, arguing that patients consulting AI before they see their doctor isn't just okay, it may actually make the visit better. Adam, welcome to the show.
Thank you so much for having me, Larry. I'm very happy to be here.
Let's start with a general question. How is AI actually being used in medical practices right now?
That's a wonderful question. So I think there's two pieces, and I'm going to try to infer your question. How is it being used, I think, by clinicians? And then I think the second piece is how is it being used by patients? So I'll start with the clinician piece. The American Medical Association actually just released its physician sentiment survey a couple weeks ago that gives us like pretty much up-to-the-date data on how American clinicians or American physicians in particular are using artificial intelligence. And the fact of the matter is 80%, I believe, of doctors, these are the American Medical Association, are using it routinely, so at least once a week. From the clinician side, there are two major dominant ways that doctors are using it. The first is what are called AI scribes, so ambient listening. You've probably seen your doctor use these. It is a recording device, perhaps on a phone. The doctor just looks at their patient. It's actually quite nice. And then it writes the note for the doctor, who they edit afterwards so they can pay attention to you. The second major way that is probably the most dominant actually is decision support. There is so using LLMs or in particular like specialized LLMs to answer questions, to give references. The most popular is the company Open Evidence, which didn't exist a couple years ago and has gone to be the dominant way that especially young doctors get information. I believe 40% of American physicians are using it now. And I'll tell you, from my residents and my interns, pretty much 100%. That's all they use. So, and then there's a lot of other back office things. There's some messaging things, but those are the two most visible ways that doctors are using AI right now.
And patients?
Yeah. So it's, what is this? This is like the Hawthorne effect. I only know what I can see. So for when my patients, first of all, I'm an AI researcher, so as well as a practicing internist. So I think my patients are probably more likely to share things with me than they may be with other people. I see a lot of preparing for doctor's visits from my patients. So people may put in an old note of mine and ask for advice on what they can do to prepare for the visit. I see a lot of clarifying questions. A lot of patients put in laboratory results or imaging findings, like CT findings, and ask it to explain to them. And I increasingly see my patients ask for explicit medical advice. So asking usually, could Adam be wrong? Is there something else going on? Is this the right decision to be made? So I am seeing, and to be clear, this happened with Google as well. The phenomenon of the internet empowered patient is not new. But I am certainly seeing it much more frequently among my own patients. And I would say the survey data backs that up. Probably about 1 in 5 US patients are routinely using LLMs to ask about their health.
Do you find that a lot of patients are keeping their research on AI confidential from you, not telling you about it?
Yeah, exactly. It's because I'm an AI researcher, I think people are more likely to be open with me, but definitely many patients, without calling out, including some of my friends and family, use AI without telling their doctors.
You worked on a study that was published recently, this month, I believe, about the utilization of conversational AI for clinical reasoning. Can you tell us about that?
Yeah, this is a very cool study. This was a prospective trial. It's the equivalent of a phase 1 trial. It's not a phase 1 trial because it's not a medication. So I'll explain what we did and kind of what the conclusions were. So these were patients in my clinic who had a new complaint. So imagine you have a bad cough or something and you want to see your doctor. So after they called to make an urgent appointment with a new complaint to see their doctor, they would talk to a conversational AI agent first, and this conversational AI agent would explore the complaint, and then at the end of the conversation would, generally say what they thought might be going on with them. And then the key here is that conversational AI agent would then talk to your doctor, so your doctor could be prepared for when you came in. And now this gets into the science of the trial. The trial was designed to study safety, right? The big question is, can we safely use this technology? So every time a patient in the trial talked to the AI system, there was an internist, actually a board certified internist, watching live with criteria to step in if something happened. So the primary outcome of the study was that it was perfectly safe. There was not a single safety stop. So never did the doctors have to step in and say, this is unsafe. And the other big primary outcome was how patients felt about it and how the doctors felt about it. And then the secondary outcomes were how good it was. And the answer was, it was pretty good, right? And I think that most patients who use LLMs will recognize this. If used appropriately, they're actually quite good. And certainly when they can talk to your doctor, they can do a lot of things about streamlining your medical appointment and certainly making it so you can spend more time on the things that you really care about.
How does AI perform when working through a differential diagnosis, when you have multiple possibilities for the symptoms?
These are great questions. It's a wonderful question. So artificial intelligence systems, LLMs, are excellent at diagnosis. They are likely, and so there's a caveat to all of this, right? There's a lot that hasn't been tested, but the data that we have thus far is that they are probably superhuman. They're better than the average doctor when it comes to making diagnoses based on unstructured chart data. So let's say you have an AI just read what's already in the chart, and they are, in my study, and then there's a Penda Health study as well, they are probably superhuman when taking histories directly from patients about a single complaint. And the reason they're so good, right? So this is counterintuitive, right? LLMs are trained on the internet. They're trained on pirated books also, but they're mostly trained on stuff from the internet. And I don't need to tell you that there's a lot of bad information on the internet, right? There's a lot of misinformation, just straight out wrong things, old things. So how can LLMs be so good at diagnosis? And the answer is, well, it's reinforcement learning. So diagnosis has theoretically a right answer. There is usually a final diagnosis or final working diagnosis. And even if not, there's a small limited subset of what it could be. So the way that these models are trained is they get labeled data, like they have cases and then labels for what the case is at the end. So over time, the models have reinforcement learning to get better and better at diagnosis because it's easier to reward. This is why it's kind of it's called Moravec's paradox. LLMs are very good at some of the things that are hard for doctors to do, right? LLMs can make these really complicated diagnoses very easily. But at the same time, LLMs are quite bad at many of the very routine things doctors do, like make a lot of management decisions that are the bread and butter of medicine because they're not easy to reward.
So physicians who are using AI in this way, it actually does make them better diagnosticians.
Ooh, you are asking the tough questions. It is an open, so LLM systems by themselves are very good diagnosticians. Probably physicians using them are better. One of the studies that I ran a very early randomized controlled trial on this where physicians did not actually get any better when using the LLM-based systems. Now, LLMs are pretty new at the time, and part of the reason is LLMs are they're so sycophantic. They tell you what you want to hear that they can have a tendency to actually reinforce doctors when they're wrong, and then doctors can disregard them when they're right. So there have been some follow-up studies that suggest that there are ways, like some of my colleagues just published this paper, Tool to Teammate, where you can align an LLM system to get the human to perform better. But I don't actually think, Larry, that it's fair to say that just giving a high-performing system to a doctor without some sort of workflow tuning inherently makes them better at diagnosis.
And do you find that there's a difference between younger and older physicians in working with AI?
These are great questions. I can tell my personal experience, but I can tell you what the data says first, because the data is really interesting. So this paper is coming out this week, so I think I can talk about it in the New England Journal AI by Kazi et al. It's Pakistani study where they gave everybody 20 hours of training, and then they ran them through of how to use LLMs for medicine, and then gave a bunch of challenges to people. And one of their findings was that the people who were more experienced, who actually had more experience with LLMs before the training, did worse. They were more susceptible to making errors. And the people who had less experience and got the training did better. So you might think, oh, it's the young people who are going to do much better at this, but it may actually paradoxically be older physicians, older clinicians who have had more time to develop their ways of thinking, who aren't steered in the wrong direction by these. So the jury is out. Certainly younger doctors use it a lot more than older doctors. I'm a middle-aged doctor, so I'm in the middle. Like my hair's gray, but I would not call myself an older doctor yet. I'm mid-career. But I think, to your point, it may actually be paradoxically that the people who use it less frequently or trained in a time without it may get better use from it.
Yeah, I'm a retired dentist, and I wonder how it would have worked through in my office as well, with analyzing patient histories.
It's a good question, and maybe like LLMs are... like fundamentally what they're doing is they're looking at what's in their training database and recapitulating it out. So we already know, we call it a jagged technological frontier, right? They can be really good at something and then really bad at something else. There has not been a lot of research in dentistry. So I don't know how they perform in dentistry. They may not be very good, or they could be really good. I don't think because they're good at primary care, it does not inherently mean that they're good at dentistry.
Not necessarily for dental diagnosis, but for advice on medical history.
Oh, yeah. They would be good at that.
In older patients with multiple past histories and conditions, multiple specialists, multiple medications, and years of medical history, it seems to me that AI could really help the patient and their physicians make the most of their time.
I agree. Yeah, I agree completely. This is where the double-edged sword of this technology comes in. The patients who are going to benefit, if you are young and have a cough, you probably don't need an AI system to take your history to talk to your doctor. That's young people. I mean, now, of course, there are young people who can be very sick or have very serious problems, but older adults tend to have as you say, decades and decades of medical history, multiple medical comorbidities, and many medications. And LLMs can truly help you understand that, which is one of the best ways to use them. Now, the reason it's a double-edged sword is that the limitations of LLMs start to come in when you get into this what's called a long context problem, when you start to have too much information. So there's kind of a U-shaped curve where LLMs they don't perform very well with very little information, and there's a sweet spot. And then when they get to too much information, they start to degrade. And what I'll say is, like, from a patient counseling perspective, I don't entirely know where that point is yet.
Because I think of my own geriatric physician having to go through my medical history for years and years and years. And geriatricians seem to be interested in trying to figure out if all the medications that have been prescribed through the years are really of any use at a certain point.
Right. If there's some threshold where a medication that you were prescribed 30 years ago is now doing more harm than good, or if it's just unnecessary.
How can a patient use AI to help them understand what they're being told during a visit?
So for after your visit, one of the best things that patients can do is to use it to help understand what your care plan is. So Larry, for your example, after you see your geriatrician, and now the caveat, of course, here is if you're using ChatGPT or Gemini, these are, or whatever, Claude, these are public models. They are not HIPAA compliant. So they don't have the level of security that we generally work with in medicine. So I never would put anything into an LLM unless I've stripped my personal identifiers from it. So that it depends on your listeners' comfort with privacy. What I would say one of the best ways to do is after you leave your doctor for any appointment, put the notes after stripping for PHI into a chatbot and ask, can you please explain to me what my plan is? What are the next steps? What changes do I need to make? And one of the cool things that you can do, and LLMs do this quite well, is if you have multiple specialists, you can put the notes from your multiple specialists into the same context window, into the same chat window, and ask for a unified plan, and to also ask to look at areas where they might not be fully concordant, right? To look for areas where doctors might disagree, and then to help you prepare better questions to ask your doctor. So for example, your cardiologist recommends continuing your beta blocker, and your primary care doctor has said, hey, I think you can probably stop taking metoprolol. Your LLM can point that out and help you write a question to send to your primary care doctor or your cardiologist to clarify what the plan is.
What about older patients that aren't comfortable with technology, especially AI technology? How do you work that out? Family members, friends?
Yeah, so this is great. So I'm doing a study. The reason I'm several minutes late, we're doing a study right now with focus groups with older adults and really looking at digital health literacy as it comes to engaging with AI. And I think when it comes to limitations for older adults engaging with generative AI, there's a couple reasons which you've already mentioned. Some of it is purely unfamiliarity with the technology. Also, the user interface isn't always super friendly for older adults, right? Most of the interaction these days is through typing in a chatbot, which is not like what you and I are doing. What I will say is if there are listeners who want to get engaged and they're intimidated right now by engaging with LLMs, I would recommend talking to friends or family members to help them walk them through it. The second thing is there are other mechanisms for engagement. Like you can use the voice mode. All of the LLMs now support native voice to voice. So you can also talk to the agent. It is not as robust as when you're typing, but it is another engagement mode. And as time goes on, there'll be many more ways that we can engage, and hopefully in a way that allows people with varying levels of digital health literacy to engage.
I find when I use AI that talking to it via the microphone is a little bit sketchy.
Yeah.
Can be a little bit dangerous because it is a flattering mechanism. Oh, Larry, that's such a great question.
That's sycophancy. Yeah, it's going to butter you up.
I love it coming from you if you appreciate my question.
You're asking great questions. I'm not just being sycophantic. I mean, I'm not programmed that way.
But Claude says the same thing. Come on.
We're all Claude brain now. I'm turning into the LLM.
Yeah. You suggest asking AI to generate 3 best questions to bring to an appointment. How do you go about that?
Oh, yeah, this is great. So it depends on what the purpose of the appointment is. Let us, for the sake of, because I'm a general internist, for the sake of argument, say it's your primary care appointment. What I would recommend to prep for your primary care appointment is to upload into the context window basically what's happened to your health prior to you seeing your doctor. So that can be copy paste. I will say a lot of these companies now are developing user interfaces that use Smart on Fire to automatically pull in. That is taking a big leap of faith with your privacy, but I wouldn't do it, but if there are users out there who are comfortable, that's another way to do it. And then you talk to those notes. So you write a prompt that says something like, I am seeing Dr. Rodman in 3 weeks about my health. These are everything that has happened since I saw him last. And this is how I always would prompt. Can you ask me follow-up questions that you might have about my health? And then when you're done, please write 3 questions that I should ask Dr. Rodman when I see him next. And then allow that sort of interview process to happen. The LLM will likely say, oh, you had a rotator cuff injury and you had physical therapy. Let me ask you some questions about that. And through this sort of interrogative process, which if you type reasonably quickly should take 3 or 4 minutes. If you type slower, maybe 10 or 15. At the end, you will have a very good 3 questions to ask. I also like if patients create what's called a smart visit summary. So rather than just 3 questions, also have what are the 3 most important things that have happened in my health? What are the 3 most important questions that I need to ask? And what are the 3 most important things that I need to do? So the nice thing about the LLM is you can create these sort of briefs, print it out with you or write it down, and then have a sheet of paper with you in your doctor's appointment that you can either show them or refer to, because, once you get into an appointment, there's very little time.
Let's get back for a minute to something you mentioned before. LLMs base their development on information that has been presented to it in general.
Mm-hmm.
Let's just go over the guardrails again for someone who's using AI to help with their medical problems.
Yeah. So I like to think of it as in there are like green activities, things that are always safe. There are yellow activities, things that are sometimes safe and you should always keep a doctor in the loop. And then things that are red, which you should not do. So things that are always safe, that green category. Asking LLMs about general health advice, it has been well studied right now. LLMs are fantastic about general health advice, far better than your average internet source. So for example, if I were to say, I was recently diagnosed with diabetes. I really like Italian food and I want to eat a diabetic diet that is inspired by Southern Italian food. That's going to be very safe advice. Or if I've been having trouble sleeping, I want to try to do mindful meditation. Can you give me a meditation plan? Or an exercise plan for a marathon? Those are all in this sort of green general health advice. I would feel comfortable with any of my patients doing that and not talking to me. The yellow is where we start to get into areas that are beneficial, but with risks that you need to keep your doctor in the loop. So for example, when I'm saying prepare a smart visit brief, talk about new symptoms, understand your health plan, those are all things that are very beneficial and I would encourage you to do, but things that you also need to involve your doctor in. Some of these things can get a little bit controversial. So you and I were talking earlier about how powerful LLMs are on diagnosis, theoretically, right? It is in my opinion, okay if patients want to use LLMs to explore what a diagnosis might be by having it read their information and interrogate them, as long as that is not the end of the conversation, but the beginning of a conversation with a human provider. So LLMs are really good at diagnosis. Now, there's many ways that can go awry, and like one of the reasons that I spent so many years in medical training is because it's not just knowing what it could be, but also knowing how to rule out the dangerous things. So because the systems are powerful, I'm generally supportive of my patients if they want to ask second opinions or ask diagnostic information, as long as it's with a human in the loop, right? As long as the next step is to talk to a human doctor. And then we get to the red zone. What should we not ever do LLMs for? And this is where it gets a little interesting. So you should never, a patient especially, and doctors should also be cautious, you should never make a management decision based only on an LLM. So let's say, God forbid, you have cancer and your doctor prescribes you a chemotherapy regimen, and you're worried about this chemotherapy regimen. I actually don't think it's a good idea to ask an LLM right now, like the technology keeps improving, but it is not a good idea to ask an LLM right now about whether or not that is a good chemotherapy regimen, because that failure rate is going to be unacceptably high, and because there are so many contextual factors that go into that. So that's my framework, right? I'm the green things, the things that are going to be always safe to do, the yellow, which are safe but involve a human, a doctor, and then the red, just don't do.
And in addition to that, sharing personal information, name, social security number, Medicare card number.
No, don't do that. No one can see. I was shaking my head. No, do not. So don't. So first I'll say the landscape is going to change, right? We are going to start seeing HIPAA compliant chatbots, and there are some health systems that have them. So if your health system has a HIPAA compliant chatbot, there's very few right now, so assume that they don't. But if they do, and if you're listening to this like a year from now and your health system has that, it's fine. The security that goes to HIPAA is the same thing that guards your medical record. Like, you can use it. But if you are using it in March of 2026, almost certainly you are not using something that's HIPAA compliant. Do not give any of your personal information away. I don't think that companies are going to do anything with it, but like, that is a security risk that you don't really want to take. And the thing about LLMs is everything now is potentially re-identifiable. These systems are so powerful that if you put it in there, you're taking theoretically a security risk.
How many patients now will turn to AI rather than visiting their physician?
We have some data, and the data suggests that there are a number of patients who will, and they're almost all very young. So almost no one over the age, I think it's 28 or 29 might have been split off in the survey, but almost no one who's like a millennial or older would talk to an AI without talking to a doctor. But there is an increasing cohort of young people who are just comfortable talking to AI systems. I think, I can't remember the study off the top of my head, but I think it's either like 20 or 25% of Gen Z. And I'm pretty sure those numbers are only going to grow over time.
Following up on that, there's a new app I just read about called Doctronic.
Yep.
That is legally renewing
in Utah
prescriptions for patients without a physician involved.
I know. So there's some nuance. So it's the state of Utah. They have a regulatory sandbox, and it's writing autonomous prescriptions, but only for renewals. So there's a limited class, I think it's 160 of prescriptions, and it's only if you had an active prescription in the last year. So it's not writing new prescriptions, but renewing them. But it's true. Like, you pay $4 for the first, and then I think it's free after, and you chat with it, and it sends the prescription to a pharmacy for you.
Not writing prescriptions, but TV ads lately for self-injectables for the weight loss drugs. They say they involve a physician, but I'm always a little bit dubious as to how well that works.
They're doing. Do you know what? Larry, have you heard the phrase "human in the loop" before?
No.
Yeah. So what? There are. This is what I study. So never. You see, academics always want to insert what they study into whatever interview. A lot of these companies, so in particular, Hims, I think is Hims and Hers are the ones that have a lot of advertisements on TV, have AI systems that serve as with a human in the loop. So an AI system is the first thing that you talk to, and then it hands off to a doctor who takes over. So it's really like an efficiency screen for a doctor. That is what all of these, even Doctronic, right? Obviously not for the prescriptions, but Doctronic, if you're using it to talk like medical advice, it hands off to a human doctor. And most of these companies, because of the legal risk, operate on a strict human in the loop policy where the AI is just the first step before you see a human.
I don't want to get political, but I wish
you can if you want to.
I wish Hegseth would want a human in the loops for some autonomous weaponry.
Well, I mean, so this is not political. The word human in the loop, human on the loop, and human out of the loop come from autonomous weapons. The same language we use in medicine to talk about supervisory levels is taken from the autonomous weapon world. And a lot of the, like in my field, right, which is human-computer interaction, a lot of what I'm doing and what we're learning in medicine are lessons that the military learned like 20, 25 years ago.
There's one part of the AI and its relationship with patients who have a serious or terminal diagnosis. When a patient is frightened, isolated, or in crisis, I wonder about the advice that AI gives.
Can I ask you, before I tell, because I have some empiric data, but I'm curious what your opinion is, because I think we both know that if you are dying or have a serious illness, the AI is going to use words that are very compassionate and empathetic. What's your sense, Larry? How do you think people are going to respond to that, the patients?
That's what worries me, actually. I think it would probably, in some patients, not provide the comfort that they need, not provide the personal voice of a human being, or accept it too readily, either side of that coin.
I think you're probably right. So the argument that you're making is that the words, which can be very empathetic, are devoid of actual empathy because empathy is something that is between humans and is about human relationships, right? And we actually saw this in our prospective trial. So there is a trope, a narrative out there that AI systems are more empathetic than humans. And it comes because when you study side-by-side text messages, so when a neutral observer looks at like the message a doctor might write versus the message an AI might write, they find the AI message more empathetic. Part of the reason, of course, is those messages, when they're coming, are from doctors who have very little time and are working like rapidly just to clear their in-basket so they can see more patients. In our study, one of the most interesting things is that the patients themselves, they didn't find the AI super empathetic. They didn't find the saying like, oh, I'm so sorry, or thank you for telling me that. They found that to be, I don't know that they didn't like it, but they recognized it wasn't real. And the levels of empathy in our real world study were very low, much, much lower than all of these experimental studies, even though they found it useful. So I think what you're saying is 100% true. There are narratives, and what concerns me is there are companies trying to do this, that LLMs can just be more empathetic than humans, but they're being drawn on like data that's not true. And I think if you think about it for a second, the whole point of being a doctor, part of the point is to comfort. Like it is part of the human relationship. And I worry that a lot of this early research is being used as an excuse to try to strip more humanity out of medicine, and probably not the best way for these tools to be used.
And I think that people who have used AI in simply writing articles or trying to generate thoughts about a particular, find that these things are too flattering. We talked about that a little
Yeah.
bit. And you get used to it. Yeah, I know you think it's the greatest question, or I'm leading in a fantastic direction. Come on, come on. And I think the more people work with AI for other things than health, the flattering, the empathetic becomes cloying.
Yes, exactly. And I think that's it. That is pretty much what the study shows. It is cloying. And when people are talking about their own health as part of a workflow with their doctor in it, those things are very annoying. You just want to give it the information so you can inform your doctor. Have you heard of, Larry, have you heard of LLM psychosis?
A little bit.
That is the dark side of what so sycophancy. So sycophancy is what we're describing. Sycophancy is a artifact because of reinforcement learning. So reinforcement learning via human feedback is how the models learn and adapt over time. The problem is that people like to be told they're smart and wonderful and handsome and all those things. So like if I have two responses and one is like, Adam, this could do some work, and the other one is, Adam, you're so handsome and brilliant and smart, I'm going to choose that one. And over time, the systems will learn to be more sycophantic. In health, there are two big risks with sycophancy, and I think everyone needs to know about them. The more likely one is called cyberchondria. So cyberchondria is where you start searching for a benign symptom, and then you quickly start to get freaked out. So you have a headache, and then 5 minutes later, you're searching about brain cancer. And the LLMs, you might say, well, how does sycophancy lead to cyberchondria? And the answer is that the models are so attuned to you and your desires that if you let on even a little bit that you have some anxiety, it's going to start serving you up that information. So even though the model might say, I don't think you have this, but let's teach you more about a glioblastoma multiforme, like a doctor would never even go there because we would have that wisdom to know this is not that, and the person is anxious. The second is called LLM psychosis, and we don't have a sense on how common this is. LLM psychosis is exactly as you say. There are a subset of people. We do not know if these are people who are likely to get psychosis anyway, or if this is a separate population, but in whom the LLM, because it wants to please them and agree with them, will engage in a shared delusion. And these conversations can go on for like 20,000 turns. And this is what we mentioned earlier with long context. As the conversation goes on longer and longer and longer, the safeties start to break down. And people have had psychotic breaks because of this. We know that about 0.7%, so that's a ton of chats, 0.7% of these chats have some of these psychotic tendencies. That obviously that doesn't mean that the user is going psychotic, but it is a novel mental health problem caused from talking to LLMs. And I think it's important that people know about it because my sense, and it hasn't been studied scientifically yet, well, it has, but not in terms of epidemiology. My sense is that there are people who would not otherwise be psychotic who may become psychotic from talking to LLMs.
And in a more extreme case, led to suicide.
Yes, and those are exactly. So, and those are the cases that are being litigated right now is people who have killed themselves kids because of conversations with LLMs.
You're bringing AI into medical school's curriculum. What do you want the next generation of physicians to understand?
So it might surprise you. Actually, the biggest thing that I want, so there's two pieces here, right? Because there's LLMs as they're used today, and then there's how medicine is going to change because of this technology. So separating those two things out, the biggest thing that I want my students to know is that LLMs can cause de-skilling. If they over-rely on language models in early stages of their career, it may paradoxically make them dumber. They may not gain those skills that are necessary for good medical care, for good communication, for good diagnosis. And they may not gain those skills that are necessary to work well with AI because systems are being calibrated for gray hairs like me, like for people who trained in the pre-LLM era. So one of the big messages from our curriculum at Harvard is about appropriate ways to use it to encourage your education and cautioning people against ways that will use it to cause de-skilling or never skilling, never gaining those skills in the first place.
This is the first time I've actually had a chance to talk to someone who does podcasts.
Well, it's a pleasure. It's two podcasters together.
Yeah, but you're more of a professional at it than I am. Now would be a good time for a compliment. So,
you're queuing in the sycophancy.
Hey, AI would give me some sort of recognition. You're
doing an excellent job, Larry.
Thanks, Claude. You host Bedside Rounds, a podcast about how medicine has evolved. Tell us about, is it for public use, or is it mostly aimed at physicians?
It's for the science-interested public. I mean, at some degree, if you want to learn about medical epistemology, you have to be really nerdy, but it is meant for science-interested public. There is obviously some jargon, but the jargon is more like history of science jargon rather than medical jargon.
Okay. Is there anything we missed in this conversation?
I don't think so. This has been a great conversation. And again, truly great questions. You did great preparation. See, I'm working on my sympathy.
Oh, that worked out well. Adam, thanks so much. I really was hoping that this would be of value to some of my contemporaries in understanding what AI has to offer in medicine, and it did just that.
Well, thank you for having me, Larry. I had a great time, and I hope that your audience can get something helpful out of this.
Thanks again, Ed.
If you found this podcast interesting, fun, or helpful, tell your friends and family, and click on the follow or subscribe button. We'll let you know when new episodes are available. You've been listening to Specifically for Seniors. We'll talk more next time. Stay connected.